Well, today we're going to talk about chronic suicide. And the distinction I want to make here is between pretty much almost all of the approach, the material, the perspective we've been talking about suicide all along is from the perspective of what we might call acute suicide. And that is that the highest suicide risk occurs in a short period of time. Usually it's a crisis in the way we have defined it earlier in the semester. That is, there's a stressful event, a person is knocked off their equilibrium and they're not able to function at their normal level of functioning. And then out of that state of crisis arises the mental health emergency of potential suicide. It's this acute situation in the context of a mental illness, but triggered by a stressful event, which leads to acute risk, typically over a short period of time. But there's an alternative model that we need to pay attention to too, which is chronic suicide. These are people who think about suicide all the time, virtually every day. And if you ask them, a lot of them say they've been thinking about suicide since they were 14 or since they were 12, or sometimes even as long as I can remember. Chronic suicide is often a part of personality disorder, especially borderline personality disorder. It may often also be a part of alcohol or drug dependence. Sometimes it's part of a chronic mental illness like schizophrenia. And I want to kind of compare and contrast these two models in the next few minutes, in this video. So acute suicide, as we've been talking about all along, utilizes crisis intervention and then the one-shot emergency intervention to determine what the level of risk is. It may be that if the person is high risk, then we're going to take charge and put them in the hospital. So it's paternalistic, it's directive. The focus is on keeping the person alive until the acute risk passes. Again, hospitalization is a part of it. With chronic suicide, on the other hand, suicide is seen as part of a maladaptive behavior pattern or a maladaptive interpersonal style of relating. And here, the idea is much more to put the responsibility on the client and not paternalistically run in and take charge, force them into a hospital. In fact, generally hospitalization is avoided as much as possible. Now, it's also important to keep in mind that the person with chronic suicide also may well have NSSI. Remember, non-suicidal self-injury, chronic cutting, burning, again, though motivated by an attempt to feel better, not motivated by any portion, really, of the behavior aimed at dying. But that does become an issue because many borderline clients are depressed, they have an empty kind of depression, and they focus on maintaining relationships with others. As you recall, one of the diagnostic criteria for borderline personality disorder is frantic attempts to avoid real or imagined abandonment. And so it's all about getting others to care for them, and an extension of that then becomes getting others to take care of them. And for other people to help them stay well, stay alive. It also leads to testing of other people to see if other people really care. Now the problem with the acute suicide model is when we paternalistically take charge, that reinforces the idea of other people taking responsibility. And with borderline clients, that will often lead to oppositional behavior, limit testing, dependent behavior, might even make them even more suicidal. And hospitalization really is a kind of extreme of that. So a lot of borderline clients get into a particular pattern that I've put on the slide here: expectation, disappointment, regression. And that means at the beginning of a hospitalization, at the beginning of a new romantic relationship, at the beginning of a new course of outpatient therapy with a new therapist, they often have very high expectations. Now I'm going to feel better. Now I'm no longer going to be depressed. Now I'm going to be cured, whatever it might be. Very high expectations. And of course, no matter what the situation is, it doesn't take long. In a hospital, it might even be on day 2 or day 3 that it becomes clear that those expectations are unrealistic. In outpatient therapy or in a new romantic relationship, it may take a little bit longer. But unfortunately, almost always, I guess I would argue always, the next step is a disappointment. And then arising from that disappointment is regression, manipulative behavior, violent behavior sometimes, suicidal behavior, again, shifting the responsibility onto other people. In an inpatient setting, splitting of staff. Also, if you recall, another one of the diagnostic criteria for borderline personality disorder is splitting, that is, seeing the world in terms of all good or all bad, idealizing some people and devaluing other people. And they do that to inpatient staff in the hospital in a very powerful way. It isn't just that they split like kids do with their parents. Mommy won't give you money to buy candy, so you go to daddy. No, it's much more like these clients, when they're in the hospital, pick out some people who seem to be a little more sympathetic, a little warmer maybe, and develop an idealized relationship with them where they see them as all good. And then other staff people, maybe someone who didn't get a good night's sleep the night before, so they're a tiny bit irritable. The client sees in a negative way, and then from then on, and that would happen on day 1 in the hospital, from then on, with the person that gets the positive side of the split, they behave in a very reasonable way. And with the staff member that gets the negative side of the split, they are difficult and manipulative and angry and oppositional, so much so that then the staff gets into arguments about what's the real nature of the patient. Is this a poor, poorly treated, abused person that needs our sympathy, or is this a manipulative, difficult person that we need to like slap them into shape, something like that. They can be very dependent, but they can also be very angry and rageful. And then, of course, in an inpatient setting, often some of these borderline clients don't want to leave the hospital. They like the hospital. There's all these people around. Now, this is especially true in a private hospital where there's sufficient staff members. This would not happen in a state facility, typically. But in a private hospital, there's people around that want to talk to you about your problems. And so as the discharge date approaches, they had been doing really well, and all of a sudden, the day before discharge, all of a sudden they have an uptick in suicidal thoughts. They begin to be acting out violently toward the staff. And so it's really important to set limits. And hospitals that do well at this would set the discharge date on the day that the client or patient is first admitted to the hospital, and then really stick with it. Now, one example of a bad outcome case is this partial hospital patient. Back when I was in Ann Arbor, not at the University of Michigan Hospital, but I worked for a while at a different hospital as head of an outpatient clinic, and one of the programs I was in charge of was a partial hospital program, a day hospital program. And there was a client who I'm going to call the case of the nurses or my friends. Now this is back, this is like 1990 maybe or something like that. The client was 28 years old. She had a diagnosis of borderline personality disorder. And believe it or not, and I know in the 21st century this is hard to believe, but in 1990 or whenever this was, this sometimes did happen. That is, she was in the hospital. She was hospitalized for about 12 of the last 15 months, meaning she would be in the hospital for a month or two for suicidal risk. She'd be discharged, she would struggle, she wouldn't do well for a week or 2 weeks, and her doctor would put her back in the hospital, where she would then stay for another 2, 3, 4 months. And then she would be discharged, she'd get out, she'd have difficulty, and she'd be back in the hospital again. Now, obviously, it seems obvious to me, and probably to you in retrospect, this is not a good idea, but it was, well, I have to say it was also to the financial benefit of the psychiatrist who was in charge of her treatment as well to do this. Again, obviously this doesn't happen anymore because the lengths of stay are so much shorter, but at that time in Michigan there were people, and I think it started with the union negotiations at the big three car industries, the unions were able to negotiate really good health care back in the 60s and 70s and 80s, so that a lot of people, and then other industries had to follow suit in order to keep up. So a lot of people had Blue Cross that covered 365 days of inpatient treatment. It's remarkable when you think about it now. So she was more in the hospital than out of the hospital, and of course, people develop, people get regressed. They get less able to cope with the outside world when that happens. But anyway, now she was discharged, and she was in our partial hospital program. And when she was there, maybe a week or two, the group took a break for lunch, and except for the Medicare people who we supplied lunch, part of the program was that for the more functional people would go out and leave the building. It was not in a hospital building, but in an office building. Would leave and go get lunch somewhere, and she and a number of other people did that. They came back, and in the first group after lunch, during a group discussion, she fell off of her chair onto the floor, and it's a long story, but she was taken to the ER where she died. And it turned out that she had taken an overdose of a variety of medications while she was at lunch that day. Now, what we didn't know, and what some of the other patients and the other clients in the partial program did know, was the story that she told them. She didn't tell us, which was while she was in the hospital, at some time in the previous year, the lease on her apartment ran out. She lived by herself, and she had an apartment in Ann Arbor, but the lease ran out, and she had to move to a different apartment. And she was able, apparently, while she was in the hospital, to look up some apartments and make some phone calls, and she was able to get herself another apartment. But when it came time to move, 2 or 3 of the nurses from the inpatient unit went with her out of the hospital and helped her move her furniture and her belongings from her old apartment to her new apartment. And now you might say that's creating a dual relationship, and that's probably a mistake, probably a bad idea. And it certainly was, because this client began then to believe the nurses were my friends. She told the other clients in the partial hospital program, the nurses are my friends, except that her birthday came up. And in fact, she told some of the other clients in the partial hospital program, I think the nurses, from the inpatient unit are gonna throw a surprise birthday party for me because the nurses are my friends. And of course, you probably wouldn't be surprised to learn that her birthday came and went. The nurses from the inpatient unit did not throw her a surprise party, and she was extremely upset. Told the other people in the partial hospital program. At that point, I thought the nurses were my friends, and that was the precipitating event, it seems, for her to kill herself. And she did, as I said, she did kill herself. So it was a tragic outcome, but it really illustrated a lot of the dangers of hospitalization, the dangers of dual relationships. So the alternative, in more general terms, outpatient treatment, it's really focused around structure and limits. The number of sessions, length of the sessions, is the client allowed to call you in between sessions? And one author that writes about chronic suicide called this model the continuing therapy model. And it really focuses on helping clients take responsibility for their lives. It's built to be non-paternalistic and empowering, even to the point where if the therapist knows the client well and knows that their standard way of operating would often include teasing about suicide or threatening suicide, then they may well take what you might call, in one kind of famous article about dealing with chronically suicidal clients with personality disorders, the therapist might take a calculated risk. And the calculated risk would be not hospitalizing the client, even if they say things like they threaten suicide or they tease about suicide. You can see what I put on the slide here. For example, the client is leaving your office, and the last thing you say is, okay, I'll see you next week. And as they grab the doorknob and walk out the door, they say, yeah, see you next week, if I'm still alive. right? And so that's designed to get them to come back in the office and what do you mean? Let's talk about that. Let's spend more time. What do you mean about it? Whereas when you know the client and when you know that this is their modus operandi, then the argument would be, which I have done a number of times, would be to say, okay, see you next week, that you don't take the bait. Now, I think a lot of people agree with that, but it's scary and people are afraid of getting sued and things like that. So here's some alternatives. Therapy that's really built for people with chronic suicide ideation, DBT, the CAMS, which we've talked about before, and then there is a model of cognitive behavioral therapy that focuses specifically on suicide. But again, what's the barrier to people really doing this is fear of litigation, fear of lawsuits. What if this is the one time that the client actually does not just tease about suicide, but actually does, attempt suicide, and what if they actually die? And, psychiatrists, social workers, psychologists, mental health professionals are afraid of getting sued. I mean, they certainly don't want a client of theirs to die of suicide, but they certainly also don't want to be sued for it. So people feel sometimes that their hand is forced, and they must put the client in the hospital if the client says, well, if you don't do X, Y, Z, I'm going to kill myself. They don't think it's really going to happen, but they feel like their hand is forced because what if it does happen? So this is I think the biggest barrier to it. Okay, so this is the idea of chronic suicide, and I just wanted to point out when we had a video, and also I posted on Sakai a number of checklists and rating scales about suicide. I posted one for acute risk stratification that was published by the VA Systems MIRECC, MIRECC. Once again, I believe it stands for Mental Illness Risk Evaluation and Clinical Center, something like that. And they focus on suicide risk and mental illness in the military. And if you recall, we had a sheet similar to this which talked about acute suicide risk. This one talks about chronic suicide risk. And you can look down and see, high chronic risk, intermediate chronic risk, and low chronic risk. And I think really in line with what I've just been speaking about a few minutes ago, if you see even under high chronic risk, some of the essential features, chronic mental illness, chronic personality disorder, history of substance abuse or dependence, limited coping skills, unstable or turbulent psychosocial status, unstable housing, erratic relationships. And the action over on the right is not hospitalization. The action is a routine follow-up, regular routine follow-up with limit setting, a well-articulated safety plan. We talked about safety plans before. Risk screening, coping skills management, things like that. Hospitalization is not mentioned. So this is maybe another example that points toward this different model when we're talking about chronic suicide. Okay, so acute suicide risk, chronic suicide risk. Okay, I'll see you next time.